We have a mixture of staff members, friends, practitioners that are interested in stem cell. We have some patients that are very interested in our stem cells. So one of the things, and basically I'd like to just ask the panel some just general questions, and then we're going to open it up for our audience to interact with you all. So the first thing is, did you make that decision to move towards stem cells?
I can speak to that first if you'd like. So, hi, I'm Lisa. Nice to meet everybody. I've been utilizing stem cells for about 5 years. I was at UCLA. I'm a UCLA girl and have advanced education there and worked there for many years. And because that's an educational platform and a big teaching institution, it gave me opportunity to be exposed to a lot of things, including really great doctors like Dr. Lurye. I was working with a physician and I had a patient that I was case managing, and she was 88 years old with Alzheimer's, and she wasn't really having a lot of protein intake, and she had breakdown like stage 3 decubiti. And I was like, I need a Hail Mary here. What can I do? And I was working with a physician, and he's like, you want to go out of the box? Because that's the kind of girl you are. And I said, yes. And so we decided that we would do IV stem cells as well as directly inject stem cells into the wound bed, into the periphery of the wound. And my moniker is, I say stem cells are not Jesus juice, because I want to give realistic expectations to patients. But those stem cells were like Jesus juice. And so that was my first real encounter. The healing was phenomenal. We had wound care consulting. We had expert wound care nurses. The healing process after 9 days was like nothing I've ever seen in 36 years of practice. And so then we started thinking about different applications. I reached out to my good friend and someone who I highly, highly respect in the OR, who's an incredible clinician, Dr. Lurye. And we discussed stem cells. Fast forward to results we had seen with patients. And he likes this part. I was in my sock monkey pajamas on a Friday night, and I called him up and I said, let's change healthcare in America, because we're antiquated compared to other countries with what's going on. And he was like, okay, let's change healthcare in America. So from there, everything kind of evolved to targeting which state we chose. And we chose Florida initially because of the patient population. Ultimately, this is great for everybody, but we want to serve patients. And then we met with people I have met and known in Florida, and we met in the lab and started networking out. And this is after we'd already treated a large number of patients and seen results. And then everything kind of evolved from there. The Florida Medical Association embraced us, and then we had our bill sponsored and then went through process. We are not politicians. That was an adventure. And then we had the law in Florida. So that's kind of like my first encounter with stem cells. Felix, do you want to address your first encounter?
Yeah, for sure. Nice to meet everybody. My name is Felix Lurye. I'm a interventional pain doc and anesthesiologist. Thank you for spending some time with us today. I initially got exposed to stem cells from the autologous nature, which are stem cells that are from ourselves. And those were being used in a variety of different indications for my patients. I was taking a large needle, reaming it into somebody's pelvis, drawing up their own stem cells, and then re-injecting it into their body, or taking stem cells from their fat tissue and re-injecting it into their body for different purposes, orthopedic and pain management purposes. And I was happy with the results, but the procedures were quite painful, and the patients weren't getting long-term benefit that I wished them to get. So I decided to look into allograft tissue, which are tissues that are from other people to us or to my patients and our patients. And those stem cells and those tissues have significant benefits above and beyond our own autologous stem cells. And so we started doing procedures, and my aha moment, like Dr. Quilmore asked about, was when we injected a man's hip, and he was using a cane, and he was barely moving around. It was a really nice guy. And about 2 weeks afterwards, he gave me a call, and he's like, Doc, I'm walking up steps without my cane. I don't have a limp right now. I'm like, wow, this is pretty tremendous. And this was one of our first patients. And the results were such that I decided to kind of expand my practice into, peripheral joints, spine, IV with Lisa, and we have been doing this for many years at this point, and it's been a really awesome journey. And we're here to answer any of your other questions.
So one of the questions that I get asked in clinic all the time is that how does these cells that are, and I kind of explain it, these are cells that haven't decided what to be yet. These are cells that are in the early lineage of cell division. And so, the question I said, well, if you inject it into a particular part, a knee or shoulder or something, how does that cell know to become that versus something else?
So the stem cells that we use are called umbilical cord derived stem cells. They are what you would call pluripotent stem cells. They're stem cells that can change into a variety of different structures depending on the type of stem cell in the product. And so they basically receive signaling markers and molecules. They exude signaling markers, and the stem cells basically communicate with their environment. And so when you inject them into an area, they look around, they see what kind of tissues around them, and they tend to convert into the types of cells that are surrounded by that they're surrounded by. So, for example, if I were to inject umbilical cord derived stem cells into bone, they would turn into bone tissue or bone cells called bony tissue. If they were injected into a joint, they would turn into cartilaginous tissue. If I inject them into a disc, they presumably turn into disc material. And so that's called differentiation. And differentiation is one of the main functions of these stem cells, and one of the main ways that we get our regenerative benefit from these types of treatments. The benefits are both anti-inflammatory and regenerative, which is a step up from other types of treatments that we are, very used to and are known to have standard of care treatment. For example, steroid, PRP, platelet-rich plasma. Those are mostly anti-inflammatory benefits with very little to no regenerative benefit. And so this therapy allows for that second component, which is pretty powerful.
Yeah, I think that's true. The other question is the rejection. The question we get asked in clinic a lot is like, how does my body know not to reject these cells?
Very good question, Dr. Kumara. One of the reasons why I use this type of stem cell particularly, after doing a lot of research, because I'm fairly neurotic dude and don't want to hurt my patients, want to make sure that everybody is really safe and gets the best possible outcomes. Turns out umbilical cord derived stem cells have a characteristic known as immunologic preference. Immunologic preference means that they're neonatal, and so they don't carry as many of the surface markers that an adult stem cell or an adult cell in general would have on its surface. And because of that, it doesn't cause things like graft versus host disease or hemolysis when injected into the intravenous circulation, or any kind of other kind of hemolytic transfusion reaction. In fact, out of the thousands of patients that Lisa and I have treated, 0% of them have gotten any of those conditions, thank goodness, knock on wood. And that's because of their characteristic of having what's called immunologic preference.
When you inject, for instance, I know the company's looking at other indications other than what we do as musculoskeletal. But can you speak towards some of the other studies, for instance, cardiac or other things that you guys were looking at?
Certainly. So obviously, we kind of alluded to it by the law that we were able to participate in, Lisa and I, which is a blessing. We included in that law not only pain management and orthopedics, but also wound care. And so wound care is a very big component of things because wounds are a massive issue. Diabetic foot ulcers, venous stasis ulcers, decubitus ulcers, like Lisa mentioned, are rampant, very common. And these umbilical cord derived stem cells have been shown research-wise to be very helpful, not only with IV injection, but also local infiltration to aid in that process of healing. Other studies that we're currently looking at performing are cardiac studies. That particularly is in regards to post myocardial infarction patients who just had a heart attack. Those patients have a tissue that's not receiving the amount of blood flow that it needs. So it's starved of oxygen and it starts to die. And what happens is that tissue in the heart starts to form into a scar. And if we can reduce that scar formation and allow those cells to regenerate or decrease the amount of them that die after a myocardial infarction, then we'll reduce the amount of folks who have or develop things like congestive heart failure subsequent to a myocardial infarction, or cardiomyopathies or arrhythmias. And so we're running a study with a group of cardiologists where we're injecting this IV and seeing if there's a significant clinically or statistically significant decrease in the amount of scar formation in the region of the heart that has been affected by the heart attack. There are studies currently out which are injecting this into the coronary vasculature itself, meaning they're in the interventional cardiology suite taking umbilical cord derived stem cells and injecting them into the blood vessels of the heart directly as a much more direct application. And that's a little bit more invasive, but also seems to have promising benefits.
What do you think the biggest downside for someone, or how would you advise someone that's on the fence and they're thinking, what's the biggest downside you see of trying this new technology?
I think that's a great question as well. So the whole reason why Lisa and I went to do this law in Florida is because we want patients to have a really robust and legitimate alternative treatment modality option that is cost effective. And once that goes nationally, this will become more cost effective. That's one of the downsides, I would say, just to be completely transparent and frank with people, is that the cost of something like this may be higher than, let's say, a steroid injection or other platelet plasma injection currently, but we're working on changing that right now. Other clinical kind of borderline contraindications or thoughts to have are people who are on active blood thinning medications, patients who have active malignancy or cancers, and people who have active infections. Those folks may decide not to or should not proceed with things like an umbilical cord derived stem cell injection for the increased risks associated with those conditions.
Sure. Todd and Lisa and Dr. Lurye, I've been a recipient of this treatment too, and we can speak towards one of our, hair restoration. I certainly went through that. Phoebe and I went out to LA and visited the clinic there and had the treatment. And I can speak that I've now got people saying, "Hey, look, you look different." And you guys have been doing that for some time. Can you walk us through that process from a patient perspective?
Sure, Lisa. I think you can take this one pretty.
For hair restoration, there are a series of labs that we also now include that we want patients to get to make sure we're putting the stem cells and the PRP and exosomes into fertile ground. Because if there's like DHT problems, and Stacy can elaborate more into that, our other partner, we want to make sure that everything is receptive for receiving what we need for hair growth. And the process is really pretty easy. The patient comes in, we numb the scalp. We go through realistic expectations with the patient. We wash the scalp, and then we have a mixture of stem cells and PRP, and then we inject into the scalp and microneedle afterwards. And then you can't wash your hair for 24 to 48 hours, depending on how intensive your treatment is. And then you go home, and then you you have a dermal roller that's 0.25, which is not too deep. And then we ask you to apply some topical minoxidil for a period of time, and that's pretty much it. We do endorse using, it does not tickle, let me be clear. It is not like the most painless of all procedures. So besides the numbing cream, we also use something called a Pronox, which you would get like laughing gas in the dentist, and it's self-regulated, and it's nitrous and oxygen together. So to like kind of mitigate pain receptors per se.
Yeah. I said we just got a Promax machine delivered.
Oh, good. I love Pronox. A lot of plastics surgeons here also use it for liposuction. You can use it for a plethora of things. I personally, if you're getting laser treatments on your face or CO2 laser and you don't want anesthesia, you can numb on up and use Pronox, and I use it. Works great.
It does work great, and I've been a recipient of it. Video has video of me, so that's really incriminating.
Here, Todd is sharing some screens, and often it's like one and done. But I find that patients kind of come in because when I said realistic expectations, that's another downside when we talk to patients and we're very realistic with them because it depends on what's wrong with the patient, but you're not going to be a Pantene model after having, some stem cell and PRP exosome treatment on your hair. A lot of people get a follow-up treatment if they want it in 6 months to a year, or maybe every 2 years. So we have to treat the underlying cause to make sure there's no more hormone deficiencies or DHT problems. Those can be addressed. And then once we utilize the stem cells, we have really great response.
One of the things that we're kind of adopting now that we're joining your journey with stem cells is really that base. Like you're saying, what you're saying, Lisa, is really our base has to be good, which means all the other things that, the living a better life, cleaner life, make sure the nutritional portion is there to support these cells, making sure that we're not doing adverse things or counterproductive things that are going to hurt the cells, or at least the growth of those cells. So we believe the same thing, that it's not just this one treatment alone. It's a combination of things to get the results we want.
Yes, sir. The other thing I'd like to mention is I do have patients that just get stem cells for generalized health. Like every 6 months, they're on like a subscription and they may get 30 million or they may get 60 million. A lot of weekend warriors, or I have a large population. We're in California and health is everything and the way people look, but they're like riding their bikes 100 miles or they're rucking over, Half Dome or something. And with that, as you age in your 40s or 50s, even, you're going to have inflamed or injured tissues that don't necessarily need intervention like you could provide Dr. Lurye could provide. So we do have IV infusion stem cells. And so those work on systemic inflammatory conditions. And I've just used IV for a ton of things. And that will rebuild collagen in your face and in your body. It has the paragon signaling, and that's the real power. And the benefit comes from what they secrete, the exosomes, the growth factors, the anti-inflammatory mediators. So, if you're in your 60s, 70s, or 80s, ideally you want to wake up every day and not have pain in your body and get up and be able to have quality of life and do what you need, whether it's 5,000 or 10,000 steps. So often Dr. Lurye will recommend, and we will couple IV with other interventions. But we do have a lot of just standalone IV. I don't know, a couple years ago, George Kittle, who's a football player for the Niners, he was talking about a lot of the football players. And we have football players at USC or UCLA that want stem cells IV. Even though they're young, their bodies take a beating. And it really does work when it comes to like any kinds of inflammation.
I was just listening to a podcast about stem cells in the state of what you guys did in Florida. And one of the take-home messages was, from a football standpoint, was that what D1 athlete in Florida that gets injured is now not going to get stem cells, right? It's legal. Then the question is, what is Alabama going to do? What is Georgia going to do? What if the Gators and Miami and everyone in Central Florida are getting it? Well, right? What's the rest of the teams in the SEC or the other agencies going to do?
Well, here's what's happening. It's not a question of if, it's a question of when. And Dr. Lurye and I've talked to other professional sports teams. So, if you're a smaller college, it's going to come from the what is it, the sponsors, the people that support the teams, or a lot of players and the colleges, their families just get it for them because it is legal. And then to couple that with hyperbaric, which is also legal in sports and not deductible by the NCAA, like you can't use GPA, you can't use BP 157. Now they're testing for all these peptides. So that will make a difference. By the way, Dr. K, Alabama got rid of taxes for football players. So they're paying them all this money and they don't have to pay state tax. Sorry. I'm a Georgia girl, so I don't think that's fair. But back on stem cells, it's not a question of if, it's a question of when and how are they going to work around the cost. I think a lot of colleges will endorse and embrace and have it on a systemic wide for the whole athletic department. I know that we've been in talks with some Florida schools. And on the Florida law, we are also talking to other states. Tennessee, the person that's sponsoring the law right now in Tennessee is the head doctor for the Titans. We're talking to Arizona. Georgia has a law out there. I think, our goal is to make this a nationwide standard. Once we do that, then eventually insurance will have to reimburse. We're a little way down the road on that, but that's the ultimate goal for Dr. Lurye and ourselves.
Sure. Hey, now I'd like to open up to the audience. Questions that you guys have of the experts?
Good. How are they sourced? Do people donate? How are the stem cells sourced? Are they donated?
Yeah. So, Dr. Lurye, do you want to address that or do you want me to?
I can speak to it if you wish, or you can do it, whatever you wish.
You can. You're articulate. You're the doctor.
So this is the most important part of this whole process for us, is that there has been in the last 10 to 15 years a lot of unregulated stem cell practices, and there's been a lot of medical tourism to other countries. And so the benefit of working with laboratories and manufacturers who are regulated by the agencies that regulate stem cell storage for the FDA approved purposes of these stem cells, which are leukemia and lymphoma, is that everything becomes regulated. Now, I'm not talking about over-regulated to a point where it's not feasible to use. However, we don't want to be working as medical professionals in the wild, wild west either. And so these stem cells are all sourced in the United States from large hospital institutions, which have labor and delivery floors. These stem cells are either being donated by the mothers, or they're being used by the manufacturing laboratories for the, again, FDA-approved purpose, and any additional tissue that's remaining is being sourced to create ancillary service products, such as the products that we use, like orthopedic purposes, pain management purposes, wound care purposes, cosmetics, and aesthetic purposes. And so everything is sourced in the United States by donors who are either donating for this purpose particularly, or as an adjunct to the FDA-approved purposes for these stem cells, which makes it a much safer process, a much more standardized process. And we know that these donors have no, infectious diseases, any major issues with their hematologic status, and we know that the product is safe in that regard.
Dr. Lurye, if you could speak also, I want to make sure they understand, with every stem cell you receive or a patient receives, it's so important, and our lab provides a viability report. So if you could address that, Dr. Lurye.
Yes, so what Lisa's referring to in terms of a viability report, also called a certificate of analysis, these labs that we work with, they basically are the highest quality labs in the United States. And the way they differentiate themselves is they provide a certificate of analysis of every batch of stem cells, showing the exact number of viable stem cells in a post-thaw analysis, which means after they've thawed the stem cells, they check to see what percentage of them are alive and ready to work in the patient's body. And not only that, is the distribution of the surface markers indicating what kind of stem cells those are. In addition, it shows that there's no bacterial load, viral load, mycoplasma or endotoxin load in the product, and they do that via photospectrometry and a variety of different like tryptophan blue type of evaluations. So we know that the product is safe. It's a very precise procedure because of that certificate of analysis, and it gives me metrics in order to certify to the patient that the product is exactly what I say it is, which is really important because my job and Lisa's job is all about precision, just as is Dr. Kuomora's and all the medical staff in your group here. And so it allows me to be quite precise with my patients and transparent, telling them exactly what's going on.
Perfect. Dr. Raj, you have a question?
I actually have a couple, so maybe I can ask them together, and then you can maybe answer them point by point. I guess the first question was more around, injecting in. I know you said orthopedic and spine. Have you done sort of disc injections, and have you done any sort of imaging to look like MRI pre and post treatment to see if there's restoration of disc height, things of that nature? Because we know disc degeneration, especially in spine, is a major factor for degenerative disease, progression.
That's a great question. I can speak to that directly. Yes. Um, I do spine procedures on the daily basis. And one of my favorite procedures to do with umbilical cord derived stem cells is an intradiscal injection. And I've done hundreds of them. And I've been pretty successful in helping with patients' subjective pain complaints, quality of life, and abilities to perform their activities of daily living. But the most interesting part to me is that patients very frequently ask for a post-procedural MRI, and I do those at about the 6 to 8 month mark. And the biggest change that I've noted is not that the disc has plumped up, is completely new, like there are any fissures that have been healed, things like that. What I see is that in degenerative disc disease, the end plates surrounding those degenerated discs have significant modic changes. And those modic changes have decreased in my patients who have gotten these intradiscal procedures, which is a very interesting and kind of novel finding that we are looking into further studying with larger institutions on larger groups of patients to see if there's some imaging and quantitative evidence for improvement in this kind of condition.
Okay, no, that's very interesting. I guess you made a comment about for myocardial infarction and reducing the scar load. Obviously the equivalent to that would be stroke, like in the brain, or spinal cord injury. Is there any data to suggest that it could be helpful, in those conditions as well?
Yes, so there are folks across the world who are doing intrathecal injections and intranasal injections of umbilical cord derived stem cells, particularly of the mesenchymal form and the muse form, and those seem to be having some benefits for patients with acute to subacute spinal injuries and also neurodegenerative disorders. I have personally not gotten to the comfort level based on the research that I've read in order to do those intrathecal injections, and Lisa makes fun of me for it because she thinks that we should definitely do it and try and help as many folks as possible. But as a physician, my number one role is do no harm. And there are a lot of nuances to injecting somebody in the intrathecal space with umbilical cord derived stem cells. And therefore we haven't done it as of yet, but it's in the works, it's in the plans. And there are new types of stem cells emerging that will be available in the United States within the year, most likely, that show significant penetration of the into the CNS, into the central nervous system. And if that is a fact, based on their preliminary data, that'll be a pretty big game changer for neurodegenerative diseases such as MS, Parkinson's, things of that nature. And we'll be able to treat those patients much more effectively, in my opinion, with just an IV infusion rather than poking somebody's fecal sac.
Okay, and I guess you mentioned, and obviously you guys have done great work with passing the law in Florida. I mean, what is the regulatory stance, like let's say here in Texas or kind of elsewhere? Because it sounds like different states have different sort of regulations, and the original use case was, as you mentioned, for hematopoietic disorders, right? So I guess the question then is this being used in off-label capacity when you do a lot of these, treatments, or what's kind of the regulatory framework with that?
Great question. So yes, we use these on an off-label basis across the country. I live in Los Angeles and practice in Los Angeles, and I practice in New York and in Florida. In Texas, it's a unique situation because Texas has the right to try laws. And because of those, it's an additional safety component in order for you to be able to use stem cells for patients who request them. In addition to that, the umbilical cord derived stem cells that I primarily use about 95 to 98% of the time are minimally manipulated, and they follow the 361 guidelines of the FDA for homologous use and such. And because of those purposes, the key is that you don't practice factitious marketing or falsified marketing. So as an interventional pain management specialist, I would never say to somebody, this lumbar epidural steroid injection is going to cure your sciatica or your lumbar radiculopathy. Just like I wouldn't say a intradiscal stem cell injection will cure your degenerative disc disease. And so for that reason, as long as you're keeping your patient's expectations in a realistic level, and you're not promising, the moon, and providing transparent, informed consent for each procedure that you perform, you're safe to provide them on an off-label basis.
Thank you.
Sure.
Yes, sir.
And it's a good job, that they met with us and gave us, we met with the attorneys, and there's a regulatory board that they follow.
Okay.
Very
And
good question.
when we went to the House and the Senate, we had like 60 examples of other things used off label, like Botox. I was like, who here knows someone that has gotten Botox for wrinkles? Because that was not FDA approved for, wrinkles before. So we use Tylenol PM or Advil PM. Benadryl is not for sleep, but we all know. So we gave a lot of examples before the House and Senate and to Governor DeSantis to give examples of using things off label. So as long as you're a physician, you can use it. Or a prescriber, sorry, not just a physician, prescriber.
I think this, one of the things is that going back to that podcast I listened to, was really you guys are in the forefront of what they're predicting is going to be eventually standard of care. But that's what the hope is. And that
Yes.
the United States will catch up with our colleagues in Asia and Europe that are, again, doing things that we haven't yet done here.
Yes, sir.
So again, we're excited to team up with you guys and to be part of this journey with you guys, and to kind of offer our patients, what we know is good science, as well as safe and effective treatment. So speaking towards I think Dr. Lurye and Todd and I talked about, I had a patient who had caudate equina. Caudate equina is where we have a patient who lost control of his bowel and bladder. And the only way he could urinate was by self-cathing and self-disimpaction, right? That was life. We did 2 rounds of IV stem cells with him. And Phoebe, can you speak towards his results?
So for him, he is no longer self-capping. So he is able to urinate, and he is now able to have a bowel movement. So that's major, because that really takes a significant toll on someone's life. Imagine not being able to go to the restroom. And so he's doing much, much better.
That's phenomenal. That's a blessing. Yeah. That's a huge blessing.
100%.
So any other questions for the audience? I think thank you for spending your time. I know, Dr. Lurye, you're tweezers, and Lisa, you're always busy traveling, keep sending pictures of where you're traveling to. All right. But thank you for everyone. Thank you for coming. And is there do you have any questions for? We have actually. Here's another. How do you ask questions? I think that you can see in your practice now.
Yeah, we have a lot of patients who come in with low back pain or some type of limitation coming in, and they want to get started with strength training. So they're always asking for any recommendations or any type of medical care close by. So we just wanted to connect and hear about stem cells. We're always trying to continue our education, and we're an evidence-based strength training studio. That's our big niche. So we'd like to learn more about the science about stem cells and how we can optimally recommend our clients to you guys and vice versa.
Great.
It sounds like you work in rehabilitative medicine or physical therapy. Is that correct?
It's more of a strength training, but yeah, we view exercise and resistance training as medicine as well. So
for sure. So I believe very strongly that any procedure that I perform with stem cells goes hand in hand with strength training in particular. There is a period of time in which I don't want patients to do a significant amount of strength training, and that's a pretty short window, a couple weeks. And the reason is because the stem cells have a pretty strong honing response while they'll travel to new areas of inflammation from microtearing of muscle or tendon or ligamentous strain. And so we hold off for a few weeks, but subsequent to that, we ask our patients to be very, very much involved with strength training, rehabilitation, and strengthening the area surrounding the joint or the body part that we've been working on. Because I tell my patients, I'm not injecting metal. We're trying to help you avoid surgery. Sorry, Dr. Kuwamura. We want to get folks We want to get folks to a point where they can strengthen their joint, and that's key because that decompresses the area and allows those stem cells to live in that area for much longer without a grinding effect, grinding those stem cells down. I have to jump off the phone call. I apologize, guys, but before I leave, I just want to leave you with one future kind of comment. We got very lucky with Florida. We worked really hard, and we believe in this, medical, advancement because, as Dr. Kuwamura mentioned, we're quite behind other countries. Places like Japan, South Korea, China, Singapore, and South America are quite advanced in stem cell regenerative medicine therapies. And through the work we've done through Florida, we've been able to help achieve laws being placed and activated and written and going through process in other states. 5 other states now are going through their own processes, and we're very blessed and very happy to be part of those laws and hopefully enact those as well, so that in the future, hopefully the near future, we can come up with a national initiative to where my patients and our patients have a durable alternative treatment modality to the standard of care treatments we know of now. And that we can do further research where we're not limited by funding, where we're not limited by, the FDA requiring millions upon millions of dollars to run phase 1, 2, and 3 trials, where we can do quality standardized research to prove that these stem cell treatments actually help our patients and further improve their quality of life. So I really appreciate you guys listening to us and joining us on our journey here.
Perfect. Thank you, guys. Appreciate it.
Thank you, my friend.
Hope to
Bye,
meet all
guys.
you guys soon.
Yeah, we'll come and visit.
We're available if you need
Yeah.
something.
I will. Thank you so much.
Thanks.
Take
Bye.
care.
Thank you so much.